Hello, welcome everyone to today's endocrinology grand rounds. We are very pleased to have one of our recently graduated fellows who's currently on clinical faculty in the endocrinology division here, working at Henderson, Kentucky. He obtained his medical degree from Pune, India. He did his residency training at Michigan and came to us in 2022. He has an excellent record prior to coming to Louisville, and we were extremely impressed by his enthusiasm, his knowledge, his eagerness to learn more, and he did extremely well during his fellowship. He did presented at the Endocrine Society and also at regional meetings, and he is going to today talk to us about X-linked hypophosphatemia. We're eager to hear from him. Rahul, you can take away.
Yes, I apologize. I had set the screen up, but it just crashed on me. I might just need a minute or two to kind of.
Right. That's what I was just texting him when I saw the blank screen. I'm like, oops, your screen's gone. So it's fine. Just if you need to, step out and start again, that's fine.
Yeah, I'm just opening it right now. Yeah, I think I got it. I'm not sure why that happened, but I'm going to start sharing the screen now. Here. Is this, Kelly, is this visible now?
Yes, I can see it now. You just have to start from your slideshow from your beginning, and it'll be fine. There we go. Awesome.
Okay, perfect.
And just make sure it will pass through. You can just forward through a couple. Okay, good. Okay, perfect. Okay. There we go. Okay.
So, like Dr. Mokshagandam already introduced me. My name is Rahul Pansare. I was a former fellow at University of Louisville, and I'm super excited to present my presentation here on, and the topic here is Rickety and Snickety. So let's see. I have no financial disclosure or conflicts of interest in relation to this presentation. My patient was a 53-year-old male, and he was referred to me for evaluation of rickets. So here you can see adjoining, there's a picture of my patient reproduced by his permission. By the time he was 2 years of age, he had bones which were bowed. By childhood, he was diagnosed with rickets, and that was done by a pediatric endocrinologist right here at our university. By his teens, he could achieve a height of only 5 feet. And as you can see, look at his mother's height and father's height, he could not achieve his mid-parental height. As an adult, he had multiple trivial fractures, was using crutches to ambulate, and was complaining of extreme bone pain every single day. He also said he was on phosphorus replacement at some point in his life. So with that presentation, it really made me curious because, when you have somebody presenting with some kind of a condition which has started at the age of 2 years, my first obvious question to him was his family history. So he did say that his maternal grandfather was shot. However, he could not verify if he had had fractures before. He also said that during that time, his grandfather was a person who never really saw doctors. So who knows? And then in terms of his parents, he did not have any concerns there. Neither parent have any fractures. However, if you did see in the previous slide, his mother's height was 5 feet 2 inches, so slightly shorter. He has a son who's healthy and a daughter who's deceased at age 2 years. No other family history there. In terms of his own medical history, he did have heart disease, had stent placement, had cardiomyopathy with improved ejection fraction, hypertension and hyperlipidemia. And for these things, he was taking medications, couple of medications for hypertension, hyperlipidemia, for heart disease as well. Nothing that can affect the bones. In terms of the bone health itself, he did say he was taking cholecalciferol 2000 international units once daily, and he was on some phosphorus replacement, but he said he had run out of refills a long time ago. In terms of his lab work, as you can see, I obtained the complete set of workup for him, and we will discuss more in detail on why I obtained these labs, because each and every lab has some meaning and some reason why we have to obtain them. But if you observe closely, there were three things that were abnormal here. His phosphorus levels were low. His PTH was marginally elevated. And if you look at his alkaline phosphatase, it was roughly about 2.5 times the upper limit of normal. So with this picture, just looking at the labs, one might instantaneously say, oh, he has primary hyperparathyroidism, because this is how they would present, although the calcium level is not high enough, but you can have normocalcemic as well. But if you go back to his family history, and really see, not family history, I mean his own history, presenting since 2 years of age, it's obvious that this is not primary hyperparathyroidism, and this is something beyond that. So I also found this X-ray here. This was actually obtained 10 years ago when he had a bad hip fracture. You can see a transverse fracture here. And there are other features that are also visible here, but I will hold on discussing those features in the subsequent slides when we actually get to the disease process. So up till now, we know that he has had multiple fractures in childhood. We know he's having bone pain every single day in his life. He's having elevated alkaline phosphatase and low serum phosphorus. So with this, my first question that I asked myself was, is this osteomalacia or is this rickets, and what does that even mean? And we will see this in the next couple of slides. Subsequently, we will discuss why phosphorus is low and how do we evaluate it from an endocrinology standpoint. And I really wanted to discuss this in this particular lecture, because I thought, that's a topic which is very relevant everyday life, and that's something important for us to know. And then subsequently, I will discuss what my patient has. So coming to the osteomalacia part, this is a fairly simple thing, and as an endocrinology we all know, but just to go over the basics, you have bone formation which has two parts to it. Part number one is where the osteoblasts produce the osteoid or the bone matrix, and this is the organic material that is secreted by the cells, and that's made up of the collagen fibrils which are stitched together. This osteoid then gets mineralized, and the mineralization process happens because of the calcium and phosphate. So think about the osteoid as the cement and the mineralization as the bricks. And if you just have cement without the bricks, your bones are going to be weak. And that is what happens, basically soft bones in the absence of calcium phosphate. So the causes of osteomalacia are, the most common cause is vitamin D deficiency. The second most common cause is low phosphorus, and really low calcium is very rarely seen. So really, in terms of your management, you should, in osteomalacia, you're thinking of either low vitamin D or low phosphorus. Again, like we said, it's important to know what rickets and osteomalacia is. And that again is fairly straightforward, because when you're thinking about either a child or an adolescent, then you're thinking of rickets, because that happens before epiphyseal fusion has occurred. And usually it affects both the pre-osseous cartilage as well as it affects the mature osseous matrix. And that causes a sublinear growth, subnormal linear growth. Whereas osteomalacia is really just a generic term meaning softening of bones, irrespective of age, irrespective of what the underlying cause is, and that's because of lack of mineralization. So if you have to take some message here, rickets is childhood and adolescence before the epiphyseal fusion and subnormal linear growth. In terms of osteomalacia, it's defined as the osteoid thickness more than 12.5 micron and mineralization lag time of more than 100 days. And I will discuss this again in the subsequent slides later. So let's see. So now we did answer briefly what osteomalacia is, what rickets is. Let's move on to the next topic here of the phosphorus. So what's causing the low phosphorus in this patient? And as you can see, this is a busy slide, but we will break it down into 3 sections and discuss each of them separately. So the first part is diet and malabsorption. Here you can see that we take in phosphate orally. It's usually absorbed in the jejunum, and about 60% of it is absorbed and the rest is pooped out. In terms of the second thing, now once the phosphorus is taken in, the phosphorus is excreted in the urine. However, the kidneys, they hold on to the phosphorus and reabsorb it. There are 3 main players there which manage this. The first one is the PTH. The second one is FGF23, and the third is your sodium phosphorus co-transporters 2A and 2C. So getting into a little bit more detail on that. Wait, hold on. I think I skipped a slide. Yeah, this one. So this is important to review that 85% of your phosphorus is absorbed in the proximal tubule. So if you look at this pictogram here, the blue one is the lumen, the pink or the red is the blood. And you can see the receptors here, the sodium phosphorus co-transporters 2A and 2C, which are located on the luminal side. They reabsorb the phosphorus from the luminal side, push it into the cell, and ultimately it gets into the blood. Here you can see there are 2 receptors on the basolateral side of the cell, which are the FGF23 receptors and the PTH receptor. And activation of both of these receptors by these respective hormones results in inhibition of these channels, and inhibiting the channels results in impaired phosphorus reabsorption. And this is kind of very crucial and important for us to know how it actually happens. So moving on to the third thing now is shift of extracellular phosphorus into the bones or the cells. Now, remember, this is a very transient process, and that's why I will not be discussing this in this presentation, because this is not relevant to us in the background of osteomalacia. So my focus will be really to look at dietary causes of low phosphorus, and then why tubular reabsorption can be impaired, causing low phosphorus. So as far as dietary is concerned, it is extremely uncommon. I did want to emphasize that do not get confused with phosphorus deficiency with low serum phosphorus. So when somebody is starving and fasting, they can very well have phosphorus depletion and deficiency. However, as soon as the serum phosphorus drops, it is mobilized from the bone through catabolization of the bone. So ultimately the serum phosphorus levels are restored. So the end point here is fasting, starvation never results in low serum phosphorus. Now there can be again a refeeding syndrome where the phosphorus of the person starts eating can gush back into the bone, and that's refeeding. But again, this is transient, and obviously that would not cause osteomalacia. The one thing that they did mention can cause osteomalacia because of long-term ingestion of aluminum containing antacids, and that happens because aluminum binds to phosphorus in the gut and gets pooped out. So basically in the first diagram, if you saw 40% gets pooped out, binding to aluminum, a lot more gets excreted and it's not absorbed. These are 3 examples which people commonly use, just because nowadays everybody has acid reflux and GERD. So you can see Gaviscon, Maxocid and Mylanta are the 3 examples. And in Mylanta, you contain almost 800 milligram of aluminum in each 10 ml. So if somebody is using it on a daily basis chronically, they can have low phosphorus. I tried to look into the studies if there's any correlation between how much of this would need to be taken for how long to cause this, but I did not find any answer there. But this is just something to keep in mind, particularly if you're seeing a patient with low phosphorus. Ask them if they are taking any of these before concluding the diagnosis. Now coming to the renal tubular reabsorption. Like we discussed, PTH is one of the main players. So it could be excess PTH, either primary or PTHRP, and famously known as the phosphate dumping hormone. And it could also be secondary. So in secondary causes, it could be vitamin D deficiency or resistance, calcium malabsorption, and then rapid correction of hypomagnesemia. Again, this would be a transient thing. Basically, low magnesium causes impaired PTH secretion. So in such individuals, when you suddenly give them large amounts of magnesium, this PTH inhibition gets reversed. PTH suddenly rises, and the secondary hyperparathyroidism that happens causes phosphate to get dumped into the urine. But again, this is transient. So coming to the next part is the FGF23 itself. Now FGF23 can have multiple diseases can have FGF23. The top 3 diseases listed here are hereditary forms of rickets, which is the familial hypophosphatemic XLH, autosomal dominant, and autosomal recessive. Within the autosomal recessive, there's also type 1 and type 2. You could also have paraneoplastic production of FGF23, which is called TIO or tumor-induced osteomalacia. And then there are 3 less common causes which are good to know and to keep in your mind is McCune-Albright syndrome and idiopathic hypercalciuria. As you know, McCune-Albright syndrome presents with a classic triad of fibrous dysplasia, cafe au lait spots, and precocious puberty. In both of those diseases, you have dysregulated production of FGF23. And ultimately, a very interesting thing is post-organ transplant. This happens particularly after renal transplant and sometimes after liver transplant. They also term this as hepatic osteodystrophy, where you can have increased bilirubin, which can be a trigger, or directly some local cytokines that are produced, which promote FGF23 production, which ultimately causes low phosphorus. So another thing that I did want to mention here is iron infusion. And this is really just to complete all of the different scenarios where you could have FGF23 mediated low phosphorus. This is commonly tested in the board exams. Again, when somebody receives this specific form of iron replacement called ferric carboxymaltose, they can have which can stimulate FGF23 production, and that can cause low phosphorus. Obviously, needless to say, one would receive a ferric carboxymaltose only intermittently. So you would see that the FGF23 levels would rise and phosphorus levels would fall only intermittently when they receive this, and it would not be sustained enough to cause osteomalacia. The last third thing that can impair the tubular reabsorption of phosphorus is something intrinsic to the kidney disease itself. So here you have Fanconi syndrome, and Fanconi syndrome really is, although it's one disease, but it really has a laundry list of things that can cause Fanconi syndrome. And we will discuss how to differentiate that during the workup subsequently. The other things important to know are genetic mutations that can affect both the sodium phosphorus co-transporters 2A and 2C. So as far as the 2C is concerned, there is the specific disease called HHRH, and HHRH stands for hereditary hypophosphatemic rickets with hypercalciuria. And that is, again, we will discuss later in the algorithm. Now, this is something that good to know in real life as well as for the board point of view as well. Other things that can cause osmotic diuresis and result in a low phosphorus are uncontrolled diabetes mellitus and then hyperaldosteronism. Both of them, because of osmotic diuresis, can cause low phosphorus. So here we discussed, a lot of causes of low phosphorus. So yes, it's very important to look at the phosphorus to see what is causing it to be low. But remember that not all of the low phosphorus equals hypophosphatemic osteomalacia. The reason is because one needs to distinguish between a sustained and a long-term low phosphorus versus a transient and a temporary low phosphorus. So really the two most common causes that we think of when we talk about hypophosphatemic osteomalacia are hereditary hypophosphatemic syndromes, the 3 syndromes that we discussed, FGF23 secreting tumors, and then less common causes, like we already spoke about, were phosphate binding antacids, as well as genetic and acquired renal tubular defects. So the next question is, we discussed so many causes, it could be gut, it could be the kidney, but how do we differentiate when we have a patient with low phosphorus? How do we know it's coming from loss of kidney renal losses, or is it coming from the gut loss? So for that purposes, we calculate something called as a TMP-GFR. So TMP-GFR stands for the ratio of tubular maximum reabsorption of phosphorus to the glomerular filtration rate. Now this is done by using a second morning void. Usually we discard the first morning void, and the second one is the one we use for using this doing this calculation. So here you can see there are 4 ingredients that are needed to prepare this recipe, and the ingredients are plasma creatinine and phosphorus, and urine creatinine and urine phosphorus. Plugging in the numbers that I got for my patient, I put them in this calculator that I used, and using this calculator, it told me that the patient's TMP-GFR was 2.09. Now keep in mind, it's very important when you use this calculator, you are extra mindful of what units you are dealing with, because there are some of the labs can have nanomole per liter and some of them can have milligram per deciliter. That's number one. So be mindful of that. The second thing that you have to be careful about is the ranges. So there are different age related range for TMP-GFR. So for an adult who is more than 16 years of age, we have to remember the range is 2.6 to 3.8. But if you're on the pediatric side and less than 16, then that TMP-GFR can change, range can change based on the age. So for my patient, it was obviously you can see that it was TMP-GFR was lower than the suggested range for his age. So this meant that there is renal phosphate wasting. So now we know for sure that he is having low phosphorus, and this low phosphorus is not because of gut losses, but because there is lack of tubular reabsorption. So yeah, so now the question is finally, phosphorus is low and we know it's coming from the kidneys, but now what do we do? What do we do next? What does my patient have? So for that, we are going to get help from the Williams textbook of endocrinology, where they have a beautiful one slide kind of like an algorithm where we will go from top to bottom and try to get to a final conclusion here. So the first point here we look at is starting from the top is if you're having somebody who you're suspecting to have osteomalacia, or you're having some clinical or radiological features of osteomalacia, the first thing that you look at is you look at the alkaline phosphatase. If the alkaline phosphatase is high, you see, is the patient having low calcium or is the patient having low phosphorus? So obviously my patient had low phosphorus. So now we will move towards the right side hand of the algorithm. The next thing you check is the TMP-GFR, and you also along with that check the urine amino acids, bicarb and glucose. And as you remember, we had said that with the renal tubular loss, you could also have Fanconi syndrome, which is a long laundry list of diseases. So for that purposes, it's important to check the urine for all these things. Now, did I check it? No, I did not check it myself. However, luckily, just before seeing me, somebody else had already ordered a urine test on him for some other reason, and he did not have any amino acids like protein, glucose, or bicarb in the urine. So that was already checked. So now we know that the TMP-GFR was low, but everything else was normal. So we are coming to the middle box here. Then you obtain the 125 vitamin D and the urine calcium, which was normal in my patient. So with that, I concluded that this was FGF23 mediated. Now the right side, if your urine calcium is high, I had told you could have non-FGF23 mediated or HHRH, which was hypophosphatemic, hereditary hypophosphatemic rickets with hypercalciuria, and that's related to the sodium phosphorus cotransporters 2C genetic mutation. So obviously now we know for my patient, the urine calcium was normal. So we're thinking of FGF23. The next obvious step is to get FGF23. So, okay, what's happening here? Okay, so I got the FGF23 and the FGF23 came back elevated at 106 picogram per ml. Here you can see the reference range is 59. So does that mean if somebody has a FGF23 less than 59, they do not have XLH? That is not true. Let's review something about the FGF23 here. So the FGFs are really a large family of polypeptides. There are several FGFs that have been studied, like some of them like FGF1 and 2. They have strong mitogenic properties for cells of the osteoblastic lineage. When it comes to FGF23, it is secreted by the osteocytes and it regulates phosphate homeostasis by inhibiting the 1 alpha hydroxylase activity in the kidney. Now FGF23 binds to the FGF23 receptors, and they use Klotho as kind of like a co-receptor there. So I did want to highlight here that with FGF23, not only we reviewed that it causes tubular decreased reabsorption of phosphorus, that's one mechanism, but here you can see that it inhibits 1-alpha hydroxylase activity as well. And what that would do is that would inhibit activation of vitamin D from 25 vitamin D to 125 vitamin D. And remember, 125 vitamin D is also important for the gut to absorb phosphorus, and even that would be impaired. So here really the excess FGF23 would have two mechanisms for low phosphorus. One is dumping in the urine, as well as the other one would be decreased gut reabsorption of phosphorus. So now when we are measuring FGF23, it's important to know that there are two different methods that we use. One is the CLIA method, and CLIA stands for chemiluminescent enzyme immunoassay, which is done by Determinar. And the other method is ELISA, which is done by MedFrontier. So now the one that I used, when I ordered the lab, they got sent out to Mayo Clinic, and the Mayo Clinic employed the ELISA test. As far as the ELISA test is concerned, this has been tested before. They had seen in 300 healthy individuals, and based on the levels that they got, they concluded that a level of 18 to 59 roughly fits about 95-96% of those healthy individuals, which is the two standard deviations. And as far as the FGF23 cutoff is related, and that's for to determine whether this is FGF23 mediated versus FGF23 independent. The cutoff there was 27, and they said that this was one of the studies that is marked here in number 2. They said that the cutoff of 27 is 100% sensitive and specific to distinguish between the FGF mediated versus the non-mediated ones. And think about it in terms of PTH, like we have the PTH cutoffs, high, normal, low, normal, which help us to determine if it's PTH mediated versus not. The same logic applies here. Again, I did want to highlight another important point is that when you are ordering a FGF23, make sure you're ordering intact FGF23 and not C-terminal FGF23, because the intact FGF23 has a cutoff of 27, which is highly sensitive and specific. When you order the C-terminal FGF23, it does not have a very specific or sensitive cutoff. It has a kind of like a range between 45 and 90, and that may not help you as much. So in conclusion, when you're ordering the FGF23, make sure what test they have used, whether it's ELISA or CLIA. Secondly, make sure you are ordering the intact FGF23 and not the C-terminal one. And then when you do get the lab, don't just discard it if it was less than 59. Remember that the cutoff there is 27 and not 59, because that's 59 is the reference range. So after the FGF23 was elevated in my patient, the obvious next step here was to do genetic testing. So I used Invitae here, and it's a beautiful website. You can go. There are like multiple genetic testing panels available. The one that I used here was the Invitae X-linked hypophosphatemia test, which is really test for one gene, and that one gene is FEX. And interestingly, my patient, came back it came back positive for this FEX gene mutation. So now the question is, what is this? So FEX gene mutation is seen in X-linked hypophosphatemia. So I'm going to, rest of the presentation will be basically discussing about this, about the pathogenesis and how to treat it. So in terms of the prevalence of this disease, the XLH is seen in 1 case per 20,000 live births. It's among the 3 causes that we discussed, the autosomal dominant, recessive, and X-linked. This is the most common cause among the 3. Usually it can be familial or sporadic. It is completely penetrant, but severity can vary among individuals within the same family. So what it means is that once you inherit the gene, you are definitely going to have XLH, but the severity may vary. Like some people may just have short stature, some people may have full-blown osteomalacia and fractures and presentation like my patient. So if you ask me, did my patient have familial or did my patient have sporadic? Honestly, I cannot answer with surety. He may have had sporadic for all we care, but if you look at his family history, since his mother was shot and his maternal grandfather was shot, one can think that maybe he had, some familial maybe incompletely, completely penetrant, but varying degree of severity in his family. And then again, with this disease, there's no sex difference between men and women. So pathogenesis wise, the gene responsible here, as we said, was the FEX, which is located on chromosome X, the short arm 22. The FEX stands for phosphate regulating protein with homology to endopeptidases on the X chromosome. This particular gene is expressed in two organs in our body. One is the teeth and the other is the bone, and it encodes a protein cleaving enzyme. Now, due to some unknown mechanism, when you have an inactivating mutation of FEX, the FGF23 levels just rise. And as depicted here, and we had already discussed this, but quickly reviewing this in this pictogram, you have high FGF23, which inhibits the sodium phosphorus co-transporters, causing phosphate excretion in the kidney, as well as inhibition of the 1-alpha hydroxylase, causing decreased activation of vitamin D, causing phosphate absorption decrease in the kidney, intestines, and both of this causes low phosphorus. So as far as the bones are concerned, the osteomalacia that happens in these individuals has actually not been studied. The reason is because most of the individuals, by the time they come to us, they're clinically really late in the disease process. So most of the times the disease that they have is HVO3. And just to go over what that HVO3 means is that when they studied osteomalacia, they really studied this well in individuals who have vitamin D deficiency. So really it was studied in the context of hypovitaminosis D osteopathy. And there they classified into 3 different types. HVO1 was increased osteoid volume and surface, but not the thickness, and mineralization was still preserved at this time. HVO2 is osteoid thickness is increased, but there is still some degree of preservation of mineralization. And HVO3 is the ultimate extreme form where you have osteoid covering 90% of the bone surfaces and mineralization has practically ceased. So based on what we see in the vitamin D deficiency picture here on the hypophosphatemia related osteomalacia, you really just see HVO3, and we do not have much knowledge on whether it progresses from 1, 2, and 3, or how it progresses, we do not know. So in terms of the clinical manifestations, everything that my patient had, we already discussed, the slow growth, the subnormal linear growth, low phosphorus rickets, bowing of the legs, all of that is seen. There is a lot of severe pain. Now, when it comes to pain, typically these patients describe pain as being dull, aching, gnawing pain. The pain particularly worsens when they are ambulating. So that kind of results in lesser ambulation, and then subsequently causes muscle weakness. Muscle weakness is typically seen more proximally, and other things that happen is gait abnormalities. Usually these individuals always have osteoarthritis prematurely. They may also have nephrocalcinosis, and nephrocalcinosis is basically abnormal calcium deposition in the kidneys, and that actually correlates with the dose of phosphorus. So if you are trying to replace somebody with phosphorus, giving them more phosphorus may cause more nephrocalcinosis. 2 other manifestations because of either because dentin is affected or otic capsule is affected, that can cause loss of dentition, dental abscess, and hearing loss respectively. And ultimately, in severe forms, people can also have craniosyn osteosis and Chiari-1 malformation. Okay. So when somebody comes to you in the clinic, this is what typically they recommend. making sure you have a growth chart there, making sure you're looking at the signs of rickets and leg deformity in particular, measuring the IMD and the ICD. IMD stands for the intermalleolar distance, and ICD stands for the intercondylar distance. And that's really basically a measure of the degree of rickets or the degree of bowing that they have in the lower extremity. Then other things that you should be doing are neurological examination, mainly to look for spinal stenosis and craniosynostosis. Hearing loss assessment should be done, and then obviously the dentition. And dentition is something we check with all of our patients with bone diseases anyways, and then gait as well. So as far as labs are concerned, I'm really not going to go into this again, because when we were talking about evaluation of phosphorus, we already discussed all of the lab findings. I did want to highlight this one point though, that, you know, if you noticed in the previous slides that my patient had mildly elevated PTH. So this is a very interesting thing, because individuals with XLH can present with mildly elevated PTH, and this is kind of paradoxical because it's happening in spite of low phosphorus and it's happening in spite of high FGF23. But why it happens, I tried to look at the cause. They just said it's unknown as yet. So that's an interesting thing. Now coming to the different types of FGF23 mediated hypophosphatemias, you can see there's like a long list here. And if you quickly move through the table, you will notice that all of them have the same presentation. There is normal calcium, there is low phosphorus, there is increased alkaline phosphatase, the urine calcium is normal, urine phosphate is low, FGF23 will be high, and PTH may be normal to high normal slightly. So really it's hard to distinguish. The only two differences that you may be able to see is with fibrous dysplasia and tumor-induced osteomalacia, you may have low calcium or normal calcium. So in order to distinguish these diseases, the main thing that we have to do is the genetic testing itself. So in terms of the genetic testing, the X-linked is the FEX gene. The autosomal dominant causes gain of function mutation of the FGF23. The autosomal recessive rickets type 1 and type 2 have their individual mutations. Fibrous dysplasia has GNAS mutation, and obviously tumor-induced osteomalacia will not have any mutation because that's a different clinical presentation altogether. Coming to the radiological features, this is something that is seen in all of the cases, may be seen in all of the cases of osteomalacia. So this is just a generic finding where you may see symmetrical biconcave deformities. They are called as codfish vertebrae. And you can see here why they look like codfish. So that's why they're named that way. The second thing, which is generic to all of the osteomalacas, you can see pseudofractures. They're also called loser zones, and they're basically loosened bands which are 2 to 5 mm in width, perpendicular to the long axis of the bone and the periosteum. And these are called pseudofractures. The third feature that is very, very specific to this particular disease, XLH, is enthesopathy. And enthesopathy is basically calcification of the tendon and the ligaments in certain sites. And that usually can get aggravated if somebody is being aggressively replaced with phosphorus and vitamin D. So remember one thing, we have to be careful with the replacement thing. And here, if you look at, this is my patient's picture. The first two pictures were just taken from Williams textbook of endocrinology. So if you look at this picture here, you can notice that on the ischium and the pelvic bones, you can see some osteophytes and kind of like some fraying, and that is the enthesopathy. The other interesting feature which my patient did have is the triradiate pelvis. And triradiate pelvis this is another picture which I took from Williams textbook, and here you can see how it's triangle shaped. Normally a male pelvis is kind of oval shaped. And this happens because of softening of the pelvic bones. Now for a man, it does not really have too much clinical significance, but if this happens in a woman, then that can cause problems with childbirth. So in terms of the treatment now, when you're talking about the treatment of XLH, the two treatments which have historically been used is to replace the active vitamin D, because FGF23 inhibits the formation of that, and obviously the phosphorus, because FGF23 is causing phosphorus loss in both the gut as well as the kidneys. So as far as the vitamin 125 vitamin D is concerned, the calcitriol doses usually they recommend 0.5 to 1. It's given in 2 divided doses. And for phosphorus, they say roughly around 1 to 2 grams of elemental phosphorus in a day. Again, that can be divided in 3 to 4 doses. It's very important that you go low and you go slow. Start low and go slow. And kind of titrate the dose based on the patient's response. These are several of the supplements that are commonly used here. And I was trying to look into whether, for example, for calcium, the way we have elemental calcium and elemental calcium, the different amounts of calcium supplements have different amounts of elemental calcium, like 40% in calcium gluconate, 20% in calcium citrate. For phosphorus, I did not find anything like that. So really, if you're planning to give 1 gram of elemental calcium, you would just give 500 milligram of potassium phosphate. You would get 2 pills of those. So it's straightforward and simple in terms of replacement. Now, in terms of the benefits here, it does improve the bone pain, and it also helps with the dental health, particularly in reducing the frequency of dental abscesses as well as periodontitis. However, histologic evidence of osteomalacia still persists in these individuals. And like we discussed in the previous slides, if you give too much of phosphorus, then that can cause enthesopathy to worsen. That can cause nephrocalcinosis, meaning abnormal calcium deposition in the kidneys, and can also worsen arthritis. So really what they recommend per guideline is if you diagnose somebody with this disorder, you have to only treat symptomatic adults, meaning ones who have pain, pseudofractures, dental issues, or planned orthopedic or dental surgeries, or they have biochemical evidence of osteomalacia, particularly elevated alkaline phosphatase. And indiscriminate replacement in everyone may not be the best way to go. Okay, moving to the next slide now. The next treatment that is more newer is the burosumab. And in my patient, that's what I used for him. In terms of the doses, there are 3 doses that are available. As you can see, they are colored accordingly. So there's 10 milligram per ml, 20, and then 30 milligram per ml. It's a weight-based dose calculation. So they recommended doing 1 milligram per kg. And it's done as a subcutaneous dose. It's rounded to the next 10 milligrams. So my patient weighed somewhere around 50 something. So we rounded up to the next 10, which was 60. And if you're planning to give 60 milligram, then you have to give 2 injections of 30 milligram per ml. So he uses 1 injection each of his thighs, and he takes this once every 4 weeks. In terms of the mechanism of action, the burosumab is really a monoclonal antibody which binds to and inhibits FGF23. So obviously, if FGF23 is in excess, the burosumab binds to this, and FGF23 levels would no longer affect the phosphorus. Okay. In terms of the contraindications now, it's important to know that if somebody has normal to high phosphorus, then this can cause the phosphorus levels to rise more. If somebody is already on replacement with phosphorus and 125 vitamin D, then one has to be very cautious. They typically recommend to hold this supplementation, particularly if the phosphorus level is already normal, and then initiate the drug. And then if somebody has end-stage kidney disease or severe renal impairment, that is also a contraindication. Hypersensitivity is an obvious contraindication. And then studies have not been done on this particular population, so they do not recommend using it in pregnancy and breastfeeding. So when I started my patient on burosumab, immediately after the first dose, he said that his bone pain had improved significantly. And even his phosphorus levels improved on their own. So the benefits here, like I said, was improvement in skeletal pain, and our osteomalacia also improves. Now, I know in the previous slide I had said with vitamin D and phosphorus, they had done biopsies to see if osteomalacia had improved, and they had said it had not improved. However, for burosumab, they had done histomorphometric measures of osteomalacia. So they had not done an actual biopsy, but they were doing imaging studies. And now the other benefits are obviously increasing phosphorus 125 vitamin D levels. It also helps in accelerating healing of fractures and pseudo fractures. And in one of the biggest study that they have done, which is listed here as number 1, they saw that compared to placebo, there was a 43% healing of fractures compared to 8% at 24 weeks or about 6 months. They also said that there was reduced stiffness that was measured by the WOMAC scale. The limitations to using burosumab are, the response to the joint and the bone pain is variable. Luckily for my patient, his bone pain improved immensely, and it really changed his life, and he was super happy with it. Second is, it can heal fractures, but as of now, we do not have data whether it can prevent fractures. And then obviously this is a very expensive drug, so insurance may play a big role here. So coming to the adverse reactions, some of the very common adverse reactions are infections. In fact, tooth infections and abscesses were noted in some of the individuals. So it's important that when a patient with burosumab comes back to you to inspect, the dentition, headaches, dizziness can be seen, constipation is seen, and then injection site reaction is another common one. Back pain, muscle spasms are also seen. It's interesting, because initially we had said in the previous slides, if you saw, that individuals who have XLH themselves can have dental abscesses, periodontitis, which is actually decreased by vitamin D and phosphorus. However, burosumab can increase the risk. So the hypothesis there is that they said that the tooth infections that happen is something that is independent of FGF23 direct effect, and that's why although burosumab prevents the FGF23 effect, it does not decrease the incidence of tooth infections, actually may increase the risk. So that was kind of like an interesting thing. And then while the patient is on burosumab, it's very important that you periodically monitor labs. For the phosphorus, obviously you're that's a main player here. You have to check it every 2 weeks for the first month. And then after that, you can space it out to every month for the first 2 months. Now, remember very importantly that it's to be measured at least 7 to 11 days after the injection to detect hyperphosphatemia. So if you've just received the injection, you have to wait for a week or 2 before you do it. And then the second thing is, as far as the PTH is concerned, that is something important to measure to rule out hyperparathyroidism, because these individuals may have paradoxical rise in PTH again. And then obviously calcium and creatinine, GFR, because higher the creatinine, more the chances of having nephrocalcinosis. And finally, monitoring, just in general, what do you monitor these patients for? So one important thing is to monitor them for bone pain. If they're having issues with mobility, send them to physical therapy. The other thing that they do recommend is getting a renal ultrasound every 1 to 2 years, mainly to rule out nephrocalcinosis while on treatment. Hypertension can also be seen in this individual and may need to be managed. And then ultimately PTH elevation, because there are some studies to show that although they may have just insignificant PTH elevation, this can progress from secondary to tertiary, and that may need evaluation and treatment accordingly. So that was pretty much it. I want to thank all my core faculty who have, particularly Dr. Krishnasamy, Dr. Moksha Gandham, who have taught me what I know in endocrinology, and that has helped me to apply that knowledge to treat and help individuals like my patient. So this was today's event code. I'm going to stop sharing the screen. And if anybody has any questions, please feel free to ask.
was a wonderful presentation, Rahul. Excellent.
Thank you very much.
So, yeah, so I know we have a few patients here in the pediatric bone clinic. They do have a good number of patients. I don't know if any of the peds faculty are here. So on the, sort of common presentations, this was more, you had a clue, it was a childhood disease from the age of 2. And, you sort of very nicely went through the differential, the bowed leg and, rickets, osteomalacia, all that. So if you see adult with nephrocalcinosis, would this be in your differential? Even if the phosphorus is low normal or something like that, or would you just sort of, are there atypical presentations where, because FGF23 is not so, easily available. And like you said, there are limitations to lab assays and, interpretation. So.
Excellent question. Yes, definitely. I think if there is nephrocalcinosis, I would kind of go through the whole algorithm, checking the calcium, making sure it's not PTH related, then checking the phosphorus, and then checking the 24-hour urinary calcium to make sure it's not like something like idiopathic hypercalciuria. Coming to the diagnosis of XLH, I feel like. And again, this is like more philosophical as well, but I don't know if the phosphorus is normal, calcium is normal, and unless they are having fractures and stuff like that, if there's nothing clinically that is significant, then I don't see the need to pursue XLH evaluation for just nephrocalcinosis. And I don't know, that's my thinking. Someone could argue that that has implications on family members and subsequent generations, so one could still pursue that, but just for nephrocalcinosis, I'm not sure. And again, this is coming from me. I've just seen literally one case here, so I may not be the best person to answer that.
Excellent, thank you. I think Dr. Mokshigan have questions.
There's a question on the chat by Dr. Winter.
Oh yeah.
So did the high FGF23 contribute to early cardiovascular disease? That's an excellent question, because he does have the heart disease early on. It's hard to say if the FGF23 is related. Now I do know that FGF23 or the XLH can be associated with hypertension. I do not know if it's associated with early cardiovascular disease.
I think Klotho is, right? Klotho can be associated with heart failure. I think I vaguely remember reading it somewhere.
Yeah. But I don't know if we can directly link it.
That's right. Yeah, that's right. But yeah.
Because again, we don't routinely measure those things to look at.
That's
It's not
true.
a common disease either, so
Yeah,
difficult to figure out. So it's certainly an excellent review. Does it overall, I don't think this medication has been around long enough to tell us much about life expectancy and what it does in the long term.
Yeah, no. But time will tell.
Yeah.
Hi. This is Stanley Levinson. I just want to ask you a question. Did your patient have any side effects from the antibody treatment?
Not that he complained of. None so far. So no dental abscesses. Nothing really. No dizziness. No constipation. He's actually very, very happy with the treatment. So yeah.
Thank you.
Any other questions?
Looks like we covered it pretty well.
Thank you.
So it was comprehensive, and so if
we much went through several questions in the board exam. Thank you, Rahul. So,
yeah,
that's really very good. Excellent.
Okay, thank you. Then I guess shall we conclude the presentation?
Yeah, so thanks, Rahul, and so we'll see you around, to visit us.
Marianne says great job, and Rohit said great presentation. So
Thank you guys. Thank you.